Hello and welcome back to the channel. So today we are talking about out of the hospital advanced life support in drowning. A bit of a long title, but bear with me, it's gonna be fun. So you're just starting a new job. You always wanted to work in HAMS, helicopter EMS, and you arrive in the hangar. You see these beautiful birds, and everybody is doing their stuff, and it's your first shift, and you are, whoa, this is what I wanted for my life. It's a hot summer day. Your base lies very close to the seashore. It's a tourist attraction, and it's a hot day. You know the beaches will be packed, and before you can even fill the bags and do your checklist, the alarm sounds and everybody starts running to the helicopter. There's a call, a drowning on the beach, and you start thinking, "Whoa, how do I drowning? What do I have to do? I don't remember. I think I skipped this class. I think I saw an online class one day about drowning," and you start trying to pull from the memory. And at least here in Brazil, we use a lot this classification of drowning degrees. So not everybody in the world use this, but we use a lot, and I think it's a good way to think about how our patient is. So the first degree is the patient that just has some cough. He drank some water, has a little bit of cough, and it's okay. You can don't even need to take to the hospital, so it's good. The second degree, you have a few rails. So when you're auscultating this patient, you have a few here and there, and just a few rails. The third degree, you have rails all over the chest, but the BP, the blood pressure, is still normal. The fourth degree, you have rails all over the place, and the patient has hypotension, so the blood pressure is low. And you think, well, when I'm doing the physical exam of my patient, now we have the fifth pillar. So we have insonation. I have access to ultrasound. Does it help me? Well, it helps, of course. When we are looking at the lung on a drowning patient, you can see you can look for B lines, and this means the amount of B lines and the amount of fields with B lines reflects how much water there is in the lungs. So how bad shape this lung is. So it's a good tool. It can help. The fifth degree is respiratory arrest, so the patient still has a central pulse, but there is no ventilatory drive. And the 60th degree is cardiorespiratory arrest. And as you are a very lucky provider, you receive the news mid-flight that the lifeguards have retrieved the patient, rescued the patient, and the patient is in a cardiopulmonary arrest, and they started CPR. Now what? What does the out of the hospital environment challenge us? What's different from the inside the hospital? Firstly, if you are talking about hams, you are in a tourist place, you might have packed beaches, and how do you land? Where do you land? How do you reach this patient? Even if you go by ground ambulance, you have to somewhat reach this patient somehow. How do you do this? It's one challenge. It's sometimes you have to be light on the skids, jump on the shallow water, and go running. Sometimes you're going to be do a little bit of a mess, and it's quite a challenge. Also, we are bringing advanced life support to this patient. So we have all these ALS gear. We have our mechanical compressor, we have monitors, we have ventilators, we have bags, and a lot of other gear. And sometimes the sand is soft, sometimes it's wet, sometimes it's far away. So we have to take all of this gear to the patient, and sometimes this can be also challenging. Upon arrival, you meet with the lifeguards. They say that they saw the patient going under the waves, and for he was missing for about 2 minutes. They were able to rescue, but as they rescued, the patient was already in cardiac arrest. It was a short flight, so you arrive about 5 minutes after the rescue. They are doing BLS, sorry, but they don't have an AED. So we have to set our staging area. You have to put our gear in the place so we can work. This is another challenge. You have mist, you have water, you have salt water that's even nastier. You have sand. Sand, this can go inside all of your gear, especially if you're talking about electronic gear. It's a pain. So we have to stage the area, prepare to try to damage as little as possible our gear. And another problem we have is the waves. The lifeguard tend to start just after the rescue. They start BLS just by the waves. And if you don't think about this, a wave may get all your staging area. So you have all your gear there, and a wave comes and wet it all, or you just have to run from it. So try to bring the patient, if possible, as far from the waves as possible. And now, how do we start? How do we manage these patients? Should we do ABC like old times, or should we do CAB? So do we go for the airway, or do we go for chest compressions? What do we do? Do we just call for help? The Wilderness Medical Association tells us for this kind of patient, our priority is still the airway. The cause of the arrest is hypoxia, so we need to solve this problem. So we need to start ventilating this patient. So our priority here is the airway. And what device should we use? Can I use just regular bag valve mask? Do I need to intubate? Can I use some supraglottic airway? We have a lot of papers that say that using supraglottic airways in cardiac arrest has good results because you don't waste time trying to intubate. It's easier to use, it's faster. But in these patients, it's not ideal. We need to have a good control of the ventilation, especially on the pressures and volumes that we are giving this patient. So the best option for this kind of patient is the endotracheal tube. So the ETT is what we go for here. And that brings our next challenge. We are on a beach. We have to lay down on the sand and try to intubate this patient. It's not easy, it's not clean, and we are always trying to see this beautiful picture, but we have the sun, and the sun will always be just by your foot or just by your head. So if it's in front of you when you're trying to see the larynx, the sun is just by your eyes and you can't see anything. Or otherwise it's on your back by your feet, and when you are trying to see, you can see all that light coming from the sun, and your blade is not illuminating enough. So it can be quite challenging to intubate these patients on the beach. Also, we go for a gastric tube on these patients because uh, our priority here is the ventilation. And if you have a very full stomach, full of water, there's not enough space for the lungs to expand. So the idea here is to take as much water from it as possible so we can facilitate the ventilation of this patient. And when we think about the airway, usually now we think about the C-spine also. So should I go for a C-collar, for a backboard on these patients? And not really, unless you have a history that goes for cervical trauma. For instance, the patient has dived on shallow water, yeah, you may think about it, but otherwise you're wasting time, and this patient doesn't need C-spine control, so we don't need this. And we go for breathing. So we have to think that the drowning patient has a lung that's very similar to the ARDS, so acute respiratory disease syndrome. It's a very similar lung because we have a lot of edema, we have atelectasis, we have a lot of fluid inside the alveoli, we have uh, all our cells are stuffed, so it's the ventilation is not good. And in these patients, we tend to be a little bit more aggressive. Usually, we are talking about 4 to 6 cc's per kilo when we are ventilating. In these patients, we go a little bit higher. We go for 6 to 8 because we need a little bit of more pressure, more volume, so we can adequately ventilate these patients. Also, does it make difference if it's a drowning in salt water or fresh water? Yeah, the mechanism is a bit different. Yeah, the salt water will pull more water from the cells to the alveoli. The fresh water will go inside the cell, but in the end, it's the same. The mechanism is a bit different, but the way we treat is absolutely the same. The only thing that really is the odd man off here is if we're talking about the drowning in the Dead Sea that has a lot of salt. But that's, I guess, this is not what most of you see on a daily basis, right? Then we go for circulation. So we have the airway, we have the breathing, and now we are going to check for rhythm of this patient. So um, on our clinical patients, we check the rhythm as soon as possible. In these cases, we are not that aggressive. We have to first get the airway, and as soon as possible, not delaying it, but it's not like so much of a priority to check the rhythm, because most of the patients that are have a cardiac arrest in a drowning situation is because of hypoxia. So either they have PEA, so pulseless electric activity, or asystole, and neither of these demands electrical therapy. But I may have a patient that has an myocardial infarction or some kind of arrhythmia, and because of that, it drowns. It may happen. It's not the most common. And if we are thinking about defibrillating these patients, we have to take care to dry the chest, because water, especially salt water, is a very good electric conductor. And so we may not deliver enough power to the heart. And also we have to take care of ourselves, because as water is a good conductor, if we are touching the water, we may also receive some of the voltage. But the good thing is that as it's such a good conductor, it tends to dissipate quite fast and quite evenly, so usually it's not a big problem for who's standing by, but we have to take care. Also, what's the role of POCUS, of ultrasound in the cardiac arrest? Again, ultrasound can be very useful, especially in these occasions. We can see if a PEA is a true PEA, or if we have um, mechanical activity. So the problem is that the heart is not pumping, or is just pumping badly. So it can uh, help us guiding our treatment. Also, sometimes we cannot see a very thin fibrillation. It may look like a flat line, and when we are seeing the ultrasound, we can see this image of the myocardial fibrillating, and this may indicate uh, for shock electric therapy. And then we go for hypothermia. So I live in a tropical country. The south of Brazil is not the hottest part of the country, but our beaches during summer tend to be quite good. We are very tourist attraction. A lot of people come to swim in our beaches, and here, even in summer, the average temperature is around 25 Celsius, and the water reaches thermal neutrality on 33 Celsius. That means that neutrality means that I'm not losing neither gaining heat from the water. So even during summer when our water is warm, I'm still losing heat to the water. So I have to think about hypothermia because these patients are actively losing heat for the water. And also, when we rescue them, they are on the beach, we have wind. And usually beaches tend to be quite windy. So we have a wet patient that is on swimsuit, um, and the wind tends to pull more heat from the patient. So hypothermia is a concern on these patients. And we know that hypothermia can be very deleterious for these patients. Also, when we're thinking about the A, B, C, D, E, we think about everything else. What else can we do for this patient? So should we use antibiotics? And not really. The empiric prophylaxis for a drowning patient is not worth it. It doesn't help unless you're thinking about someone that drowning in the sewer, and then we may think about prophylactic antibiotics. Otherwise, we are going to use antibiotics for treatment if the patient has any sign of infection. Also, for steroids, there's not very good evidence, so we tend not to use it either. Thankfully, you intubate, you start ventilating, you keep CPR, and you see, lo and behold, the patient is alive. Now it's time for post ROSC care. So we are going to check for BP, saturation, maybe use pressors, maybe give volume if we see that the patient still has some low preload, and we have to run to the hospital. And when we arrive in the hospital, we give the patient to the ER folks so they keep the care of our patient, and we get ready for the next call. If you have any question, any comment, leave below or just hit me up on Instagram. Thank you and see you next time.